Hi, my name is Isaac and I'm a final year medical student at Swansea University, and this is episode 2 of Up to F1 Speed, a new podcast for medical students. This podcast is aimed at medical students who are intending to work in the British healthcare system upon graduation and will address common medical and surgical emergencies you may be expected to encounter and manage as an F1 or a house officer. I decided to address these topics in particular, as when I've spoken to colleagues casually, it's this kind of thing that I'm most concerned about dealing with once we begin work. I hope that these podcasts can be used as a basic revision or refresher tool, and that they can be used so you know the important details if you are faced with these situations during work. These are topics that you will have covered as part of your medical school curriculum, and therefore I want to keep these relatively short and concise, so I won't be delving too deeply into the intricate physiology and biochemistry of each situation, but this might be touched upon where it's particularly relevant. Before we begin, I'll quickly go over the basic structure of the podcast. I will open with some basic questions as a way of introducing the topic and also so you can assess your own level of knowledge before we dive in. Then I'll begin the basic teaching on the topic, which I'm going to try and keep as concise and relevant as possible. And then after that, there'll be some more questions on the information covered. So hopefully you'll be able to see some improvement from the opening questions, and you should be more comfortable and confident answering these questions. And hopefully you'll be able to see some progress from before you listen to the podcast. After that, I'll wrap up and I'll talk about some feedback I'd like from any listeners of this podcast who are willing and able to spare the time. With that said, let's begin. Okay, so as I said before, this episode is going to focus on acute asthma. I chose asthma as, like MI, it's one of those sort of headline scenarios in acute medicine, and it's also one of those scenarios that can be incredibly scary and daunting the first time you encounter it, as the patients can be very, very unwell. Just as a disclaimer, this podcast is going to focus on acute asthma in adults. While there is some transferability to asthma in children, there are some important differences, so just keep that in mind. Acute asthma in children is a separate topic that I may address in a later podcast. So we'll start off just like last time with some questions to introduce the topic. I'm only going to ask 2 this time, as I felt in the previous episode this section ran on for far too long, but let me know if you preferred it one way or the other. So we'll just begin with the questions. So question 1, which of the following is the correct initial dose of nebulized salbutamol when treating an acute asthma episode? So the dose of nebulized salbutamol when treating acute asthma, the initial dose. So A, 1 mg, B, 2 mg, C, 5 mg, or D, 50 mg. So I'll go over those again. A, 1 mg, B, 2 mg, C, 5 mg, or D, 50 mg. Okay, question 2. If in your assessment of a patient, you notice that the patient cannot complete full sentences in one breath, what is the minimum severity of asthma that they can be classified as experiencing? So you've got a patient with acute asthma and you're assessing them and they can't complete full sentences in one breath. What is the minimum severity of asthma that they can be classified as experiencing? So the options are A, moderate, B, acute severe, C, life-threatening, or D, near fatal. I'll go over those again. A, moderate, B, acute severe, C, life-threatening, or D, near fatal. Okay, so hopefully you've had some time to think about those questions. We'll just go over them again. So the first question was, which of the following is the correct initial dose of nebulized salbutamol when treating an acute asthmatic episode? And the answer was C, 5 mg, or the other ones were incorrect. And the second question was an acute asthmatic patient who can't complete full sentences in one breath, and the minimum severity of asthma that they can be classified as experiencing is acute severe. Okay, so now we'll move on to the topic itself. Okay, so just a brief introduction to asthma. So asthma is a chronic inflammatory condition of the airways that manifests itself with wheeze, chest tightness, coughing and breathless, and it can be exacerbated by many things such as allergies, cold, exercise or more. And an acute exacerbation can be very serious and potentially life-threatening, and it's this phase of the disease that we're going to focus on in this episode. We're not going to focus on the chronic management. So I touched on this before, but like the classical presenting patient might be breathless and wheezy. They might be producing excess sputum. They also might be tachypneic with prolonged expiration. But obviously this can apply to quite a few conditions that you need to keep in your mind when you're dealing with a patient like this. So some important differentials to consider would be like an acute COPD exacerbation, a pulmonary embolism, a pneumothorax, pneumonia or an other infective cause. Some less obvious ones might be anxiety or GORD or foreign body aspiration. There's loads of other things, so you just need to keep those in mind when you're seeing a patient like this and not just to focus on one diagnosis. So how I recommend you approach these patients. So like with the MI, if you as an F1, you're going to be seeing these patients either in A&E or on the ward. And as with any acutely unwell patient, it's best to approach these patients with the classic ABC approach that you should be familiar with. I went through the ABC approach in the previous episode for MI, but I'm going to try a slightly different way of doing it this time because it got quite long-winded last time. But I would appreciate it if you could let me know which style you prefer in the feedback, which I'll talk about later on at the end of the podcast. But I'm just trying to assess which one's more useful for the listeners. But as with the MI, I wanted to talk about a scenario where you're on call and you're bleeped to see a patient who is unwell with shortness of breath or difficulty breathing, and you're not sure how to handle it. So there's a few things you can ask the ward staff to do for you before you arrive to see the patient. And like last episode, these come from the MDU's Hands-on Guide to the Foundation Programme, which is a really good book that I wholeheartedly recommend. So things you should ask the ward staff to do before you get there: ask them to assess a respiratory rate, pulse rate, blood pressure, O2 sats, and do a peak flow if they can. And these are really important, and these should be able to give you a head start on the assessment of the patient before you get there yourself, and it just saves time. And similarly, like last week, a final point before we move on to assessment and management: if you go to see a patient who is very ill or you feel like you're in over your head, don't be hesitant to ask for help from an experienced colleague. And if you believe the patient to be peri-arrest, consider putting out a crash call imminently. And this applies to all acute scenarios, not just asthma and MI, which are the ones we've talked about so far. So with that said, we'll move on to the assessment and management. So onto the assessment of these patients. So as we mentioned before, in an acute scenario, you should always use a systematic ABC approach when assessing a person, such as someone suffering from acute asthma. I'm not going to go into the details of the ABC approach this episode like I did previously, and as I mentioned before, I'm testing out a slightly different method of delivering this information. If you prefer one way over the other, I'd love to hear your feedback on this, which I'll talk about at the end of the podcast. In acute asthma, there are ways of stratifying patients into different levels of severity, and this should guide your management, and you should be able to achieve this by employing the ABC approach. So in acute asthma, we split patients into 4 groups. We have moderate exacerbation of asthma, acute severe asthma, life-threatening asthma, and near-fatal asthma. And I'm going to explain how we do this. The following guidelines are summarised from the Oxford Handbook of Emergency Medicine, which in turn is based on the British Thoracic Society guidelines, and I'll provide links to both. So a moderate exacerbation of asthma, so it's all those symptoms we talked about before. They've got worsening symptoms, and they have a peak flow rate of 50 to 75% of best or predicted, and none of the features of acute severe asthma, which I'm going to go on to next. So a moderate exacerbation, worsening symptoms, a peak flow of 50 to 75% of best or predicted, and no features of acute severe asthma. So acute severe asthma, which is the next stage up, is any one of the following. So any of these qualifies a patient as having acute severe asthma. So an inability to complete sentences in one breath, a respiratory rate of greater than 25 per minute, a heart rate of greater than 110 per minute, or a peak flow rate of between 33 and 50% of best or predicted. So I'll go over those again. For acute severe asthma, any one of the following: an inability to complete sentences in one breath, a respiratory rate of greater than 25 per minute, a heart rate of greater than 110 per minute, or a peak flow rate of between 33 and 50% of best or predicted. So the next stage is life-threatening asthma, which, similarly to the acute severe asthma, they only need one of these criteria to qualify as having life-threatening asthma. So cyanosis, exhaustion, confusion or coma, feeble respiratory effort, O2 saturations of less than 92%, a silent chest, bradycardia, arrhythmia, hypertension, partial pressure of oxygen of less than 8 kilopascals, or a peak flow rate of less than 33% of best or predicted. So I'll just go over those again because there's quite a few of them. So life-threatening asthma is any one of the following: cyanosis, exhaustion, confusion or coma, feeble respiratory effort, O2 sats of less than 92%, a silent chest, bradycardia, arrhythmia or hypertension, a PO2 of less than 8 kilopascals, a normal PCO2 of between 4.6 and 6.0 kilopascals, or a peak flow rate of less than 33% of best or predicted. So that's quite a lot to remember, and these are all available on the British Thoracic Society guidelines or in the Oxford Handbook of Emergency Medicine or a lot of other sources, and I'm going to provide links to those in the show notes, so don't worry if you can't remember it all. So the next stage is near fatal asthma, and this is the most severe of all the classifications. and that's defined as rising CO2 and or requiring mechanical ventilation with increasing inflation pressures. So near fatal asthma, rising CO2 and or requiring mechanical ventilation with increasing inflation pressures. So as an F1, if you encounter a patient that you assess as having life-threatening asthma or above, then you should be seeking senior assistance, as that's beyond the competencies of an F1. So near fatal asthma, you shouldn't have to worry about too much, at least. Okay, so with that said, I'll move on to the management and how you should manage these patients. So this is the treatment, the treatment for acute asthma. So hopefully, from your patient's signs and symptoms and also your structured assessment, you've been able to accurately diagnose that your patient is suffering from acute asthma, and you have stratified them into a severity level you are comfortable treating yourself. And if they're above that level, then you've sought senior assistance. That's where you should be at this point. The aim of this section is to cover how you should be treating these patients. These guidelines are summarised from the Oxford Handbook of Emergency Medicine, which is in turn based on the British Thoracic Society guidelines, which, as I mentioned before, I'm going to provide links to. So the first thing you should do with any of these patients is to sit them upright and allow them to hold onto the handrails of the bed. This allows the patient to use their accessory muscles to assist with their breathing effort, and it'll just make them more comfortable. Then the next thing you should do is to start them on high flow oxygen straight away. This is an obvious step. I'd be surprised if anyone who was treating these scenarios didn't do this almost innately or almost automatically. The first medical intervention you're going to do, initiate nebulized salbutamol at 5 milligrams. If they have a poor response to this or they're experiencing severe asthma and above, you should consider continuous nebulized salbutamol. So that's nebulized salbutamol 5 milligrams. If they have a poor response or they're experiencing severe asthma and above, consider continuous nebulized salbutamol. The next step is to give the patient corticosteroids, either oral prednisolone at 50 milligrams or 100 milligrams of IV hydrocortisones if they aren't able to tolerate oral treatment. So next step, corticosteroids, either oral pred at 50 milligrams or 100 milligrams of IV hydrocortisone if they aren't able to tolerate oral treatment. Okay, so the very next step after that, so if the patient continues to have a poor response, then the next step is to add nebulized ipratropium bromide at 500 micrograms. So if they have a poor response, add nebulized ipratropium bromide at 500 micrograms. If your patient is still not improving, at this point you should be seeking senior help if you haven't already, as the next steps need to be initiated by someone more senior than an F1, though I'll go over them briefly, and that is IV magnesium sulfate and IV aminophylline or theophylline. So if after ipratropium bromide your patient still isn't improving, you should be getting senior help if you haven't already, and they'll be starting things like IV magnesium sulfate and aminophylline or theophylline. So just quickly, I'll summarise that all again. So first thing you do, sit the patient upright and allow them to hold onto the handrails of the bed. Then start them on high flow oxygen if you haven't already. Then start nebulized salbutamol at 5 milligrams, and if they have a poor response or experiencing severe asthma or above, consider continuous nebulized salbutamol. After that, you need to start the patient on corticosteroids, either oral prednisolone at 50 milligrams or 100 milligrams of IV hydrocortisone if they can't tolerate oral pred. And if the patient continues to have a poor response, the next step is to add nebulized ipratropium bromide at 500 micrograms. That's all. Those are all the levels that would be expected of an F1. And if the patient's still not improving, then you need senior help, and they're going to start things like IV magnesium sulfate and aminophylline or theophylline. So that summarises the acute management of acute asthma. Patient with significant asthmatic events will likely need to be admitted to hospital as inpatients and may even need ITU support. But I feel that as beyond the aims of this specific podcast, I wanted to focus on the immediate treatment, though I do advise you to look up the guidelines around this if you're unsure or if you want to know more. With that said, I'm going to move on to the closing questions and then wrap up the podcast. Okay, so the second lot of questions. I'm going to continue with just asking 2 questions instead of 3, just to save on time. So which of the following is not a recognised classification of acute asthma severity? So A, acute severe, B, life-threatening, C, critical, or D, near fatal. So I'll just go over that again. Which of the following is not a recognised classification of acute asthma severity? A, acute severe, B, life-threatening, C, critical, or D, near fatal. And then the second question, what is the appropriate dose of oral prednisolone for a patient suffering from acute asthma? So the dose of oral prednisolone for a patient suffering from acute asthma. A, 10 milligrams, B, 20 milligrams, C, 25 milligrams, or D, 50 milligrams. Okay, so I'll just go over the answers now. So the first question was, which of the following is not a recognised classification of acute asthma severity? And the answer to that one was C, critical. All the other 3, acute severe, life-threatening, and near fatal or all recognised classifications of acute asthma severity. Critical is just one I made up. And the second question was, what's the appropriate dose of oral pred for a patient suffering from acute asthma? And the answer to that was D, 50 milligrams. All the others were too low doses. Okay, so that's it for the asthma episode, the second episode of the podcast series. Thank you very much for listening, and I hope that you learned a bit about asthma. Whether you like the episode or not, these initial 2 episodes are part of a university project that I'm completing, so I'd very much appreciate any feedback you have for me regarding this episode as well as the series as a whole. I'll be very interested to hear if you preferred the specific AVC breakdown I did in episode 1, or if you like the more general overview I did in this episode, as I'm not sure which is the better approach at this time. If you would like to provide formal feedback, I'll provide a link to a questionnaire I've produced in the show notes or video description, depending on the format you're consuming this. And if you could take the time to fill this in, I'd be really grateful. It's really helpful. If you would like to provide more informal feedback, you can do that by either commenting in the comment section if you're listening on YouTube, or by contacting me via the show's Twitter page, which is at UpToF1SpeedCast, and the 1 in F1 is the number 1, not spelt out, or the email address, which is uptof1speed@gmail.com. And again, the 1 is the number 1. I'd particularly like to hear what you liked or disliked, found particularly useful, and any ways you feel I could improve the podcast. I'd also like to hear any tips you can share with other listeners in regards to the topic of this podcast. So any ways you personally approach treating asthma, or how you assess it. And that's it. Hopefully you enjoyed these opening 2 episodes, and I'll see you again for any future episodes. Cheers. Bye. Okay, so this is just a list of references for the second episode of the podcast. The first reference is from Donald A, Stein M, Scott Hill C and Chavda S, published in 2015, and that is the Hands-On Guide to the Foundation Programme, 5th edition, published in Chichester by Wiley Blackwell. The second reference is from Wyatt J, Illingworth R, Graham C and Hogg K, published in 2012, and that is the Oxford Handbook of Emergency Medicine, 4th edition, published in Oxford by Oxford University Press. The third reference is Walker B, Colledge N, Ralston S and Penman I, published in 2014, and that is the Davidson's Principles and Practice of Medicine, 22nd edition, published in Edinburgh by Churchill, Livingstone, Elsevier. And the fourth and final reference is from the British Thoracic Society, published in 2016. That's the BTS/Stein British Guideline on the Management of Asthma, retrieved from www.brit-thoracic.org.uk/standards-british-guidelines/BTS-British-guideline-on-asthma, retrieved on the 17th of January 2017. Thank you.